unanticipated difficult intubation. Now, which is the most commonest fear as an anesthesiologist you face when you are doing case? And that is inability to intubate that patient. And which is the most unanticipated difficult. You are not prepared and suddenly you are unable to intubate that patient. Now, is this a nightmare for anesthesiologist? Not at all, because we know these are very difficult intubation. Anybody who is not even working in anesthesia can tell this is a very difficult intubation. Or nightmare for anesthesiologists is these patients. Here you can see that this is very easy to intubate, but actually tube is not going. And on this topic, I am going to talk today. So, when you call it is a difficult intubation, if a trained anesthesiologist using his conventional laryngoscope takes more than 3 attempts to intubate, or he is taking more than 10 minutes to intubate this patient, then we call it as a difficult intubation. And more important than that, what is difficult ventilation? When you are trying to ventilate the patient, but still there is no signs of adequate ventilation, means patient is desaturating, you are unable to put the mask or properly ventilate, and patient is not maintaining the saturation above 90%. Then we call it as a difficult ventilation. So the flow of my presentation will be, can we prevent unanticipated difficult intubation? If at all we face it, what we should do? What are the tips for safe passage? And one or two interesting cases in the last. Now, can we prevent unanticipated difficult intubation? So let me tell you all predictor of difficult intubation. If you are well versed with that, whatever madam has just told me, if you carefully see these patients, if you carefully suspect those patients, naturally it won't become an unanticipated difficult. Once it is anticipated difficult airway, you can deal with it. But generally, the causes for unanticipated difficult airway are around or below the vocal cords. So you may not many a times able to anticipate. In generally, there is a history of radiation, previous tracheostomy, previous oropharyngeal surgery, any congenital disease, syndromic patients, vocal cord diseases. When you suspect, there are high chance that this patient is likely to have unanticipated difficult intubation. Now, causes for difficult intubation is, one is big cause is patients. But apart from that, there are two important causes, is anesthesiology, we ourselves. Many times we are not prepared. We have inadequately assessed the patients. We have inadequate equipments in our hand. We may not be that much experienced to deal with such a situation, or maybe we are following some poor techniques. That is why such workshops are arranged to refine our technique, to change our perspective to see towards the same. Equipment check. This is very, very important. Many times, simple standby case, and suddenly that starts desaturating, and you try to gather laryngoscope, and you come to know that laryngoscope light is not working. So, if you remove these two causes, you are removing most of the causes of unanticipated difficult intubation. So, it is very, very important. You must remove these two causes when you are practicing in anesthesia. Now, what are the predictors of difficult face mask ventilation? Madam has already told about this difficult intubation, so I will not. But in general, whatever all causes of difficult intubation you suspect, they are more or less the same causes, which where patient you are unable to ventilate the patients, and so you must suspect this because all difficult face mask ventilation are always difficult intubations. What are the signs of inadequate face mask ventilation? They are very, very important when you are working. When there is absent or inadequate chest movement, there is absent breath sounds, patient is developing cyanosis. Instead of chest expansion, stomach is inflating. There is gastric ballooning occurring. Hemodynamic changes of hypoxia, patient is not maintaining saturation, or there is exhaled CO2 is not visible on inside CO2. These are the all signs of inadequate mask ventilation, and where you are likely to go in soup, you are likely to go face the complications. Now, suppose at all you face it, what to do? first and foremost things that you must do is you remain cool. Because your calm mind is the ultimate weapon against such challenge. Because if you become panic, whole OT scenario become panic, and everyone becomes haywire. Nobody knows what to do. Always call for help. Whosoever, maybe senior staff in OT, if possible, senior colleague in our site OT, or preferably anesthesiologists. Always keep difficult intubation kit ready, and you must check it beforehand. Simple things like, can you control his airway? Simple ambu bag, is it ready? All sizes of masks are ready. Laryngeal masks, whether they are ready. Proper set tubes, one or two size smaller tubes, are they ready? They are very, very important. Nowadays, video laryngoscope are coming in a big way. But still, even if video laryngoscopes are available, people are not using it because there is some kind of inertia to use it. But let me tell you, you must practice video laryngoscope in normal patient. Today, we are going to give you a lot of practice about video laryngoscope. Why? Because video laryngoscope change our vision. When you are doing our conventional laryngoscopy, you are looking at larynx from this distance, and with a very small angle, you will be able to see the larynx. When you are looking through video laryngoscope, your vision is at this level, like this. With conventional laryngoscopy, only 15%, maybe 20% larynx is visible. But when you are using D type of blade or video laryngoscope, different blades, almost 60% more angle you will be able to see. But unless and until you practice it, you will not be able to put the tube. Larynx is visible, but intubation is a bit difficult because there is some learning curve for this use of video laryngoscope. Now, whenever you face such situation, always concentrate on ventilation and not on intubation. Intubation is always elective things. You can call an expert for that. But if ventilation is problem, you are going to be in a soup. Patient will not die of hypercarbia. Patient will die of a hypoxia. So avoiding hypoxia is our primary aim. Always in whatever intubation you are going to do, always continue with high oxygen or at least oxygen flow by nasal oxygen or mask, because it gives you some degree of safety. It offers you a safe apnea period. I will give you one example. When we do a brain dead testing, we just disconnect the ventilator and we collect the ABG sample, and we want to see that his ABG, even after rising PCO2 of more than 10, patient is still not breathing, which is one of the sign of brain dead patients. So for that patient who is not breathing, we disconnect the ventilator for more than 8 to 10 minutes. But at this time, we put a small cannula into his endotracheal tube. With high flow, we continuously give oxygen. The reason being, because when you are supplying high flow oxygen, automatically that alveolar air is get replaced with oxygen, and we get a more safe period for intubation. So always give high flow oxygen. Avoid trauma. This is very, very important. If you are panic, you are trying too many things, and once there occurs a trauma, then this intubation is going to be a very, very difficult. So always, as our in Hippocrates oath said, primum non nocere, means first do no harm. That is very, very important when you are facing this kind of situation. And always, you are not a superhero. If you don't intubate that patient, it's all right. You can call for help, you can intubate that patient. But if you fail to plan, you are planning to fail. So you can post that patient later on, but safety is very, very important. Now, these are various guidelines to manage unanticipated difficult airway. Madam has already mentioned most of the. I will not go in details of that, but just you first try with intubation. If it is not possible, then you declare it failed intubation, and immediately you switch on to a supraglottic airway. If supraglottic airway, yes, whenever you are putting supraglottic airway, at least give some time. If you are putting iGel kind of supraglottic, it takes at least few minutes to iGel to get adjusted for ventilation. There might be, obviously, you might be feeling that it is not properly placed, but if at all there is some ventilation going on, wait. This is very, very important. Otherwise, in that panic situation, you are likely to remove that and you are going to do something else, which again might be a very harmful to the patient. If this supraglottic airway also fails, you go for face mask ventilation. You try with different technique. Might be you are giving relaxant, might be you are changing the mask, all these things. And even if with this you are unable to ventilate the patient, unable to do this, then you declare it is a cannot intubate, cannot ventilate situation, and you have to switch for a surgical access. There are different guidelines. Previous guidelines were thus Difficult Airway Society. These guidelines by Indian Society of Difficult Airways. There are some changes. Means in these guidelines, they say that continuously you give oxygen with 15 liters oxygen continuously throughout when you are intubating them. These are the finer guidelines, but overall, the general message is the overall same. Now, this we are going to demonstrate you on table. Means if at all there is a very difficult intubation, but if you can able to put a laryngeal mask airway, how to intubate through laryngeal mask. I'm sorry for this slide, it is not properly visible. We will show you on when we are actually demonstrating you this. Now, I'm not going to talk much about surgical PONA because there is a separate talk on this. So I will skip this. But only one point I will mention. You must prepare this kind of ecothyrotomy instrument set. It is a very simple, take large bore intracath, maybe 14 number attached to or 5 ml syringe and our 5.5 or 5 number endotracheal tube adapter to it. They are very, very helpful in OT, and this must be kept in all OTs who deal with unanticipated difficult intubation. Now, practical problems with unanticipated difficult airway is first is anxiety, fear that sets in and whole things go haywire. This is very difficult to remember these algorithms, what to do next if such situations happen. And in that scenario, there is a kind of mental block sets in. Now, what we should do for it? Basically, we should remember that there are only 5 ways by which we can establish alveolar ventilation. 2 are surgical. 3 non-surgical, one is face mask, one is supraglottic airway, and other is endotracheal intubation. And surgical is either cricothyrotomy. Now, how to remember this? How to be work in that panic situation? For this is a very interesting vortex model or approach to such kind of intubation. This is vortex is a 3-dimension like cone, and it has a red area which is a safe area at the periphery and blue area inside, and we have to remain in the periphery. The meaning of vortex is bhavra, means it's like you are going for an intubation. It's like you are entering in some challenging situation. Now you must take care that you will not enter here. You have to remain at the periphery. Means you will maintain the saturation of the patient while doing all those things. What things you are doing? You are trying face mask ventilation. You are trying supraglottic airway. You are trying endotracheal intubation with the help of all maneuvers, all whatever gadgets are available. But you will not go here. Once you go here, it will suck you inside. It will put yourself into trouble. That is why it is very, very important to maintain alveolar ventilation and maintain the airway patency. There are multiple ways, multiple manipulation, multiple steps by which we can remain at the periphery of this vortex. So they may be like, suppose you are using face mask, maybe use face mask with 2 hands, remove the denture of the patient, use different kind of face masks, use oral airways. All these measures you can do, but try to ventilate the patient. That is the very, very important. Cornucopia of airway tools means abundance of tools are available to manage this situation. But your primary goal is to maintain the oxygenated patient. You have to remain at the periphery, and that is very, very important. Lastly, 2 slides. This is a 26-year female, Telugu speaking, 48 kg, no criteria of difficult intubation as such, only previous history of adenotonsillectomy. On laryngoscopy, view was like this, nothing is visible. Then we tried with fiberoptic, small slit and trachea could be visible, and the diagnosis was oropharyngeal stenosis. Retrospectively, when we asked patient in her language, vernacular language, there was a history of dysphagia for solid since 5 years, slight change in voice and history of snoring, and patient had nasopharyngeal surgery few years back, maybe 10, 20 years back, which caused oropharyngeal stenosis. So such kind of situation you may face. Our second last case, 75-year male posted for simple lap cholecystectomy, no significant history, no any external criteria for difficult intubation. Laryngoscopy cords are visualized very easily, but 8-number endotracheal tube tried, it was not going. 7.5, 7, 6, everything is tried, but no tube is going. So lastly, 5.5 size tube is placed. Patient was retrospect further subjected to investigation. There was a diffuse idiopathic skeletal hyperostosis. This is a condition where there will be some hyperostosis here, which will prevent the entry of the tube inside the glottis. Such kind of situations you may face when you are facing unanticipated difficult intubation. So the take-home message is meticulous PAC is the crux to prevent unanticipated, because we don't want unanticipated difficult. We want anticipated difficult airway. Aim is always ventilation. Vortex model is very practical. We have to keep ourselves at periphery. We want to oxygenated patient. Always keep difficult intubation cart at ready. Even if you are giving a simple sedation, always check whether ambu bag is there, laryngoscope is there. This is very, very important. And always remain cool and face the storm confidently, because you can learn to prevent the storm or you can learn to ride the storm. If you can learn to ride the storm is not a problem anymore. Thank you very much.